begin recording and you should go ahead and get ready to start.
Okay. I will go ahead and start with our slides. So welcome everybody to our annual Interfaith Grand Rounds. This has become a tradition over the past 5 or 6 years here at Harborview. My name is Leah Klug. I'm one of the palliative care chaplains at Swedish Medical Center. I currently work at the Swedish Issaquah campus. I've bounced around a little bit, so I've also been a palliative care chaplain at University of Washington Medical Center and Harborview Medical Center. And now I have the great honor of sharing the screen and sharing the platform with my colleagues, Rabbi Jason Levine and Dr. Hoda Mohammed. Rabbi Jason Levine has shared with us in the past his perspectives on end-of-life care with the Reformed Jewish tradition. And Dr. Hoda Mohammed is a doctor of nursing practice and works at Swedish Medical Center. So shout out to the home team. Some people wonder, why do we talk about different faith perspectives on end of life as part of palliative care? But spirituality, as many of you know, is central to the practice of palliative care. We utilize the definition put forth by the National Consensus Project. So all of you palliative care nerds out there, the National Consensus Project actually created the guidelines for what palliative care is. And they came up with a consensus definition in 2009, led by Dr. Christina Pachalski, out of George Washington University. And when we talk about spirituality, we mean that aspect of humanity that refers to the way individuals seek and express meaning and purpose, and the way they experience their connectedness to the moment, to self, to others, to nature, and to the significant or sacred. And as we walk through serious illness and end of life with our patients, I think we can all recognize that we see them connecting to what is most important. And we often ask our patients, what is most important to you right now? What brings you joy overall? And then we start to recognize what those things are in ourselves as well. I'll just go through a few quick reasons why we do this work, why we have spiritual care providers, and why it's important for us to really connect to our patients where they're at. Steinberg and others talked about cultural and religious aspects of palliative care, saying it's important to realize there's an entire system at play when we do palliative care work that includes the patient, their family, their physicians, and other healthcare providers. In order to provide the best possible care to patients and families at end of life, it's important to understand their own cultural constructs as well as their individual preferences. And that's a huge part of what we do in every palliative care consult. The problem is there's a little bit of a gap in care, and that's what we want to help address today. In a 2000 study of cancer patients approaching end of life, and there are studies across patient diagnoses that come up with similar findings. 74% of patients felt their spiritual needs were met to a small extent or not at all by the medical system, and 42% felt they had little to no support from either the community or the medical system. So we're not asking about faith. We're not delving into what is it that supports you and brings you that joy. In a 2004 study considering whether patients would like their physicians to invite conversation about patient spirituality, 83% of patients wanted their physicians to ask about spiritual beliefs in at least some circumstances, particularly when faced with serious or terminal illness or the loss of a loved one. So they want us to talk about that in the consult. And overwhelmingly, the research also shows that doctors, nurses, health professionals that aren't trained as spiritual care providers like I am and like our chaplains are, they feel like they don't have the education to ask those questions. They feel like they don't have the background or the comfort level with that. And that's part of why we want to be here with Grand Rounds. We want to present some of our experts, some of our folks who know a great deal about this, and give you the opportunity to ask questions. So the next time you go into that patient room, you feel like, gosh, I really can ask about what's important to this patient. I really can say, hey, as we're here in the hospital, what do I need to know about your care in order to provide you with the best possible experience? So I'm excited to bring you two perspectives on the end of life. And we have Rabbi Jason Levine from Temple Beth Am in Seattle, who's going to present the Jewish patient perspective. And then we have Dr. Hoda Mohammed, who's going to present a Muslim patient perspective. And then we'll have time for a question and answer afterwards. So first off, I'd like to hand it off to Rabbi Jason Levine from Temple Beth Am. And oops, Rabbi Jason, I'll stop sharing so we can see your amazing face.
Okay, time to begin?
Yes, please.
And remind me how much time you would love me to cover.
20 glorious minutes.
Oh
I know
goodness.
usually I squeeze you into nothing and then you're left. If you have extra time, it's okay. We have question and answer.
I will definitely leave time for questions. So thank you all for welcoming me this morning. Thank you all for being here this morning and being open for these conversations or for this learning. As is very appropriate with the Jewish tradition, I encourage as many questions and conversations as possible. We are people who are known to discuss, debate, argue, and wrestle. I would rather you ask me something about Judaism, about end of life care, about something else, even if you're worried about offending me or might sure you got it wrong or stereotype. I'd rather you ask me and get an answer as opposed to not ask and leave here not knowing. So I really encourage you as much as possible. Definitely have an informal approach. And I'm just honored to be here to join for Grand Rounds. Once again, it's been a highlight of my year. Each year I've been able to be here. So thank you, Leah, especially. My wife says hi. She used to work with Leah as well. So she's downstairs with our toddler. Absolutely. Even though I work at a Reform synagogue, I'll explain what that means in a minute. Leah, do you have the documents? Was that spread around for people to refer to, or not necessarily?
The Grand Rounds, if anyone doesn't have Jason's documents, I'll put them in the chat right now.
I'm having trouble hearing. I don't know if I'm the only one.
Can you hear me now?
Yes.
Okay, I'll put the documents in the chat box for you.
Excellent. Just because sometimes documents, notes are helpful. I'm also a visual learner. It's a lot of words, so I apologize for that. I'll have to work on that for a future year. Even though I do work at a Reform synagogue, I'll explain what that means in a minute. I want to try to reflect the Jewish community at large. I'm by no means an expert on anything about Judaism, and I can't speak for every Jew everywhere, which actually leads to the first point, my middle point, and the final point, which is don't assume, ask. I know that should not be rocket science for any of you amazing professionals. First off, let me thank you for all the work you've done over the past year and a half. It has truly been miraculous and unbelievable. So I don't know if you get the full appreciation, but I just wanted to let you know as an outsider, especially those who have worked with people who have been in the hospitals and medical settings over the past year and a half with COVID and otherwise, you all truly are lifesavers. You are miracle workers. So thank you all for everything you have done and continue to do. So the Jewish community is quite diverse. And just because you know what I'm sharing today, or because you might have heard one person from one perspective speak about the Jewish views, most Jews have a very different perspective. There's an old joke that you can ask one question to 2 Jews and get 3 answers, or 5 Jews and get 10 answers, whatever. So the best way to find out what a Jewish person wants is to ask them. And a lot of them may not even know what end-of-life care exists in Judaism or end-of-life beliefs. So you actually might, even after this 18 minutes we have left, you might know more about this than many Jews do. On the other hand, you might have some Jews who come from a particular tradition, often Orthodox, who have a very clear and specific idea of what they want, and it's best just to ask them. So if you refer to the document or just listen as well, just starting at the top there are a number of different denominations in Judaism. The largest denomination in Judaism is the one which I am part of, which is 35% of surveyed Jews identify themselves as Reform. Reform, it's not Reformed ED, but Reform, and it's more of a progressive approach to Judaism that definitely embraces modern medicine and modernity. It is less rituals, less rigidity. So they often may not know what different end-of-life practices are in Judaism, but they've been open to what is meaningful to them. Next would be around 18%. I should update these numbers. We just had a study come out a couple of months ago. but the numbers aren't drastically different. Conservative Judaism, around 18% of the Jewish community, they kind of bridge the gap, embracing both modernity and ritual observance, probably closer to Reform than Orthodox in practice. The Orthodox is around 10% of the Jewish community. Orthodox is actually a spectrum itself. So don't just think the stereotype of black hat, black outfits, and sideburns, things of that nature. Although those certainly are part of the Orthodox community, there are a number of approaches to Orthodox Judaism. Again, best to ask. Orthodox Judaism is much more focused on ritual adherence, and they often would have more specific or clear ideas of what rituals or life-saving or non-life-saving medical practices they would like. If you add up all those numbers, you get that 36% of the population is not affiliated with any movement at all or belongs to another denomination, such as Reconstructionist, Humanist, trans-denominational, post-denominational, a lot of other terms which are part of this community, renewal. And that means most Jews don't belong to a particular denomination. By the way, belonging to denomination is not necessarily as strict as it might be in Christianity or other groups. A lot of Jews kind of float between the denominations. But because most Jews don't belong to the denomination, they don't have a particular tradition they follow. And if you ask them, what synagogue do you belong to, or who's your rabbi, or what tradition you belong to, so you can respectfully follow their beliefs, they may not have an answer, and they might struggle to give you a synagogue or rabbi that they connect with who can answer some of your questions. So again, be open, share with them the possibilities. If you have some Jewish resources, if not, and spiritual and pastoral care do, we're happy to connect people. But again, ask them. Moving on to the next section of the slide, if the one Jewish value we're going to learn today is called pikuach nefesh, which means saving a life. It is one of the most overriding values in Judaism. It overrides almost anything else in Judaism, which is the value of saving a life. So most Jews will want every medical intervention possible to save a life. That being said, one of the reasons I was late this morning, this is on the phone with a congregant, and she wants no medical saving, no medical intervention and whatsoever. Speaking to her daughter, who's getting pushback from more traditional parts of her family, saying you have to give her because Judaism says. And this woman has made the choice, and we abide by it. So in the end, it does come down to personal choice, of course, but most Jews will, if I can speak broadly speaking, will go for as many medical intervention as possible. The term quality of life does not actually come up too much in Judaism. It comes up more in my community, Reform community, or maybe non-affiliated or unaffiliated Jews. But when you're getting towards more of the Orthodox community, there really isn't a question about quality of life. It's you live or you don't live. So you can certainly have those conversations, but don't be surprised if you're working with the Orthodox community if they kind of don't consider quality of life to be a factor. If you can save a life, you save a life. End of story. We do not believe that, this broadly speaking, Jews do not believe that death is a punishment or that a trauma is considered to be the consequence of an action you have done. We don't believe in karma or divine response. We believe that death is a part of life. And similarly, Judaism, as I love this phrase that I wrote, is famously ambiguous about what happens after you die. The most common view nowadays, and there's been many views throughout our 4,000-year history, is that our soul lives on and reunites with God, and all other souls, our physical body returns to the earth. Judaism and practice and belief is very focused on this world. We don't have because it's so ambiguous, Judaism does not have a strong focus on what happens after you die or afterlife. The work we do, the rituals we do, the commandments we follow are for the sake of our lives here. So one thing about Judaism is discussion about going to a better place or notions of that nature will mean next to nothing for Jews, and in some cases might be insulting to Jews. So I would not use the concepts when you're trying to console or comfort someone towards end of life. I would not use phrases like going to a better place, things of that nature. That is not a common practice in Judaism whatsoever. It might be comfortable to some, of course, but I would not, but generally speaking, it is not a common phrase that is used in the Jewish community. Looking at our time, we have what, 6 minutes, 8 minutes? Just want to time check it. You're muted.
Oh, sorry, we've got like 10 minutes.
Oh, yeah, right. Fantastic.
Plenty of time to argue.
In turn, because I'm just waiting where I go to rituals. Okay, so let's talk about end of life and definition of death. Definition of death has actually changed a little bit in Judaism over time. And it's now classified more around brain death, although for the longest time it was, it was heart death. In terms of end of life care, in terms of medical intervention, now we're talking more towards the ritual side of things. The legal side of things, Judaism is much more legal than people quite realize. When I was in rabbinical school, my sister was a second year of law school. My first year was in Jerusalem. My sister came to visit me. She just finished her final exams. She sat in some of my classes, not sure why, but she was curious. And she commented after class, like, this felt like she was back in law school, because so much of Judaism is very ritually driven, legally driven. So in Judaism, you're required to, again, this is kind of talking from the rabbi level here. A lot of Jews who are your patients or your families may not know some of these legal details, but I'm sharing them with you anyway. In Judaism, you are required to preserve life, but not to hasten death. Might sound quite clear and different to many of you. For some, it feels like it's the same thing. So you're prohibited, you're not supposed to hasten death, but you're not supposed to delay death as well. So you don't hasten death, but you don't delay death. So this would permit the removal of medical machinery if it is the only thing keeping someone alive, such as hydration or artificial nutrition. But there are, of course, different schools of thought about whether you could or cannot keep somebody on various medical machinery. Again, consult the individual family. The most famous examples about these from old Jewish legends or Jewish text are, if somebody is dying and they're hearing a woodcutter outside, and that rhythmic chopping of wood sound is the only sound keeping a person going, you're allowed to go out and stop that person from cutting wood, which think that's similar to a medical, to a machine keeping someone alive. You know, that is if that an external source is the only thing keeping someone alive, you're allowed to stop it. In another story, it's a bit intense, but another story is a rabbi being burned alive. We can talk about anti-Semitism separately if you'd like, but Rabbi being burned alive, his students encouraged him to open his mouth to let the fires inside to allow him to die more quickly. Another story is Rabbi was dying and his students were praying for him. In this case, it's a hymn in my tradition. Anyone of any gender can be rabbi. And the students were praying and praying and praying, and the rabbi was just ready to die. So his aide actually went to the top of the roof and dropped a clay vessel, which shattered, shocking the students. So they went down to see what would happen, effectively stopping the prayers of what she was doing, again, allowing the rabbi to die. So again, most cases, you're not supposed to delay death, but you don't hasten it as well. Again, depends on the individual person. Moving into rituals towards end of life. As a person nears the end of life, you traditionally don't have, somebody's supposed to be with them at all times, to be comfort with them, to not be alone with them, and more, the community is a very high value in Judaism, very high value in Judaism. So you'll often see a lot of people coming around, people being together, praying together. There is a prayer at the end of life. Technically it's a confessional prayer, but don't think of it in terms of Catholic confessional, but there is a confessional prayer called Vidui. Any Jews on this call might recognize that phrase that we just did it at Yom Kippur. It's a similar phrase, Yom Kippur, the Jewish day of repentance. Happened a couple of weeks ago, took up a lot of my time. It's a similar prayer. It can be recited, if somebody wants this end of life prayer, it can be recited for them, over them, even over the phone. We've done that a lot in the past year and a half for obvious reasons. So you can recite an end of life prayer over the phone. Once somebody does die in Judaism, funerals typically take place as soon as possible. Some might even want that funeral within 24 hours. Most, I would expect it within a few days. because of arrangements have to deal with nowadays. You have to possibly wait for some immediate family member to travel in from out of town. But the big thing, I know my colleague will speak about this, the Muslim tradition as well, there's definitely a high value in burying quickly. So how that affects some of your work, this might mean getting a death certificate very quickly. If there's a medical examination that's required, getting that relatively quickly. And just I'll mention a note on that too. Autopsies are accepted in Judaism. In many cases, it's only accepted if it's medically necessary. But if there is a medical need for an autopsy, it is permitted. But yes, so as quickly as soon as possible, often within a few days. So expediency is definitely a high value when someone dies in Judaism. The funeral is usually within a couple of days. So you might think things might move very quickly. You might ask to process paperwork or whatever appropriate steps relatively quickly. And I would encourage you to help with that if at any possible, especially since I know sometimes it's hard on a Friday afternoon or a weekend to process those sorts of documents, but please help it if they can. Jewish funerals do not happen on Shabbat. Shabbat is the Jewish Sabbath, which is from Friday at sundown to Saturday at sundown. Because in Judaism, days begin and end in the evening as opposed to at midnight. So that does offer us a bit of wiggle room if somebody dies on a Friday, but again, funerals happen usually within a day to a couple days. Again, autopsies are permitted, but nothing too extreme. It's seen as an unnecessary invasion of the body if not needed. Most Jews do permit organ donation because again, back to the value of pikuach nefesh, of saving a life. And if you can save a life by donation of an organ, that would supersede any concerns. The concern is that most Jews, when they are buried whole, but if you can save a life, then most certainly do so as well. I'm just gonna look at my time. I'm gonna offer 3 points, and there's more notes I have here about rituals and practices, and I have details. I'm happy to answer any questions about that too. I have comments here about living wills, ethical wills. You don't know what ethical will is. It's pretty much a moral statement of your values before you die, advanced directives. So the last 3 comments I'm going to make are around death with dignity, a final comment, and oh my, what was my 3rd one? Oh no, oh no, oh no. I have comments here on brain death, infants and children, suicide. What was it? We were talking about burial quickly, end of life. In Judaism, there's actually a myth. Most people think there's a prohibition against cremation. There's actually not, but most Jews think you're not allowed to cremate. There's even a belief, which is there's actually no source for it. There's even a belief that you're not allowed to bury in a Jewish cemetery if you're cremated. Technically, that's not true, but a lot of people still hold that view very strongly. So even though cremation is very common in the non-Jewish community, it's actually very much less common in the Jewish community, to the point where if you're working with an Orthodox family or somebody more traditional and you bring up cremation, they might really be shocked. Then again, some people do cremate. For example, my family does cremate. And I would say in my synagogue, I believe the number in the general population is around 80% cremate. I could be wrong, but I think it's quite high. In my synagogue, anecdotally, I would say it's around 1/3 cremate, which is still quite high for Judaism, but quite low for the general population. 2 last thoughts are around death with dignity. It is incredibly hard to reconcile Jewish law with death with dignity, to the point where it's probably might be impossible. That being said, for example, my community embraces it and welcomes it. We just had somebody complete it 1 week ago, and somebody else going through it. So again, you might be surprised, or speak to the family if that is something that you are dealing with. Some Jews might think that's completely abhorrent to their tradition. Some communities like ours accept the family's wishes. And lastly, my last point, as I am, I think, on 19 or 20 minutes, is in terms of palliative care itself. Some people might be shocked by it or think of a stereotype connected to hospice or palliative care, but truthfully, someone's psychological and spiritual care is so crucial and really helps somebody through end of life and through the last days and weeks. And honestly, for most Jews, palliative care most ethicists, most rabbis, palliative care is underused and should be used so much more, might even mandated in some cases. So we want to embrace what is available to help people mentally, physically, psychologically, spiritually, beyond their physical needs. And we want to support people as much as possible and whatever care you can create and muster in the last days of life. And again, speak to each family as their views and their practices are their own. So I think that's 20 minutes. I think I did it.
I think you hit it right on. So good
Boom.
work.
All right.
Everyone, hold your questions for just a couple minutes or just 20 more minutes, because Dr. Mohammed is also going to share with us now her perspectives on Muslim tradition and of life. And it's interesting, Rabbi Jason, that you mentioned there are intersections, because I love hearing about kind of those areas of overlap. I've had families ask for a floor discharge, Jewish and Muslim families, so that the patient would never go down to after death services or the morgue in the hospital, so that we can more expediently honor their loved one after death. So I think that is something that I've seen held in common. And now, Dr. Mohammed, would you be willing to share your slideshow with us? Wonderful.
Hello, good morning. Let me just go to the front of my slides here. Is everybody able to hear me okay?
I can hear you quite well.
Oh, perfect. Okay, so this presentation, first of all, my name is Hoda Mohammed. I will go into my education, but I just want to preface this with saying that this presentation, I'm not a chaplain. I have what I would consider maybe a little above average on knowledge about Islam as a religion, but I did do my my capstone project in examining gaps of palliative care at Swedish Medical Center. And so I have quite a bit of research background that I'm going to include in this presentation, as well as my own experience going through and using palliative care through my father-in-law, who had passed away just about a year ago. And so we had gone through this whole thing while I was pursuing my doctoral program at UW. So I've been a nurse for 10 plus years, and I have really no conflict of interest. The main thing to remember, like I said, is this is really based on my capstone project, the work that came out of that, as well as my own personal experiences in what I know of the religion. And also just as a person that's in the healthcare field, I get called on a lot by my own community and family members to oftentimes be kind of a middle person between healthcare and families dealing with healthcare crises. So I think one of the first things I would say is a lot of providers, when they're dealing with Muslim patients, might find a huge amount of people in the rooms, like just visitors around the clock. It's not that that's their family, it's that in Islam, it's actually every Muslim has 5 rights over another Muslim, and 2 of those are pertaining to illness. One is accompanying a funeral procession, and the other is to visit the sick. And so many families will have visitors of people that they might not really know, and they might not consider very close to them, come to the hospital and visit the sick. And so I think as providers, one of the things you can never assume is when you walk into a room that everybody there is supposed to be there, or everybody there is very close to that family. That might just be, 2 people who are from the community, and maybe a son is there. So I think it's important to kind of open the invitation that, you have important news to share, who's okay to stay and who's not. And many people, especially if they're outside of the family or removed from the family, will step out. So end of life consideration, I think one of the things we have to start with is the tenets of palliative care. So one of the things with my capstone project that I really delved deeply into was the tenets of palliative care and how they kind of intersect with Islam in terms of palliative care in terms of affirming life, easing suffering, and treating the dying with compassion and dignity. And in Islam, I think this is the same thing with just some nuances, right? So affirming life, for example, meaning you want that life to be elongated as much as possible. Not necessarily quality, but really life is very important. Easing suffering, I will talk about suffering a little more, as well as dignity. What is spiritual dignity, what is physical dignity, and preserving that for a Muslim patient. I think the other thing realizing is that a lot of Muslim patients will show kind of a patience and kind of a stoic presence about them, and saying that, you know, patience is really a kind of act of worship. And so having patience during the time of illness is really very important. And so sometimes you'll find that some pain medication, some psychological illness, I'll talk about that. A lot of those things will be masked by this act of patience and act of worship, really. And then the other thing to keep in mind is when patients when they're going through the serious illness or terminal illness, they'll try to seek spiritual treatment on top of having actual medical treatment. And so you'll find the two kind of happening at the same time. And in my situation, in my personal situation, this did happen. We had the imam of one of the mosques in South Seattle come to the hospital and read Quran on my father. And so that really is important. And I think one of the things we can kind of, it has to be like several people, right? So it has to be like 4 or 5 people reading different parts of the Quran on that person. And so it can seem like it's disruptive and it can seem loud. And I think as providers, it's kind of important to kind of really keep in mind and support that and nurture that, because that's part of the spiritual part of palliative care. Because many hospitals and institutions don't have a Muslim imam, a lot of these families are kind of forced to kind of seek that out on their own and bring them in. And I think as providers, trying to put maybe a sign up and saying, or as a healthcare facility, that this is what's happening in there, and let's respect this time, I think is really important. Islam really dictates on all aspects of life, like all religions do, in terms of suffering, death, dying, and even life after death. But I think we have to realize that Muslims are not really monolithic, and there's huge difference of cultures that bear on what a person who's going through end of life is going to experience. And then there's even differences in adherence, right? So everybody's not going to be your ultra adherent, and there's going to be people that are going to be, they say, they feel they're Muslim, they are Muslim, they will tell you I'm Muslim, but you know, things that might be important to one patient is not going to be important to another. And I think keeping that in mind is really important. But at the end of the day, it will dictate a lot of, even the person that doesn't know that will have people from the community that will kind of help them kind of navigate that. And so it will inform their value system, their cultural perspective, and really mortality and end of life transition. I think one of the biggest things that I experienced, I remember, was prognosis. When we first received our prognosis, it was set in a way that that kind of put a limit. It was, you have 2 weeks, you know, and that was that. And so I think to kind of put it mildly, my father said, you know, well, I wish he had the time in his hand, isn't it? It's not up to him. And so, and I think a lot of you can foster the kind of that relationship and kind of a respectful relationship if you approach it from the point of, you know, it's understanding that a lot of Muslims believe in this idea of predestination, which says that everybody has a death time that's predestined. And this is really helpful to the Muslim patient because it takes it away from them, the idea that they have to have it takes away from them the burden of like feeling like, oh, I did something to cause my death, or I made choices to cause my death. That burden is taken away. It's your time is your time. You're not going to be moving that forward. You're not going to delay that. So that's that. And so I think that's really helpful. And as providers, I think we have to consider that when you're approaching a Muslim patient and telling them, hey, you have 2 weeks left. I think prefacing it with something like, hey, I understand that this in your tradition that, things, you have your time is pretty set. But in my experience and my and doing this for however many years, this is what I see the prognosis of this illness being. I think prefacing it in a way like that might come off a little more respectful, and also I think facilitate that conversation, because remember, there's even more difficult conversation that had to come after that, like goals of care, which we couldn't even talk to the doctor about because we've already kind of severed that relationship, right? And so, and then afterwards, palliative care, hospice later on, all those conversations have to build on a good first, I think, conversation. And that happens when you have to deliver that first poor prognosis. I think one of the things that is really important, and I know it's also important in Judaism, is that suicide is very, very, it's not allowed. And so a lot of patients feel like when you're offering analgesia or sleep medicine, you're kind of hastening that and trying to help a patient along. And so a lot of patients might say no to that. The other thing is there's also the idea of redemptive suffering. And so redemptive suffering is that idea that pain and suffering is a way of expiating sins. And so suffering is two kinds of suffering, right? There's a suffering we can remove by giving pain medication, and then there's the suffering we cannot take away. Let's say you've had surgery and a doctor comes and says, hey, I'm going to give you some pain medication, but remember, we're going to bring that pain down to a 4. That's about it. That's all we can do, okay? So that remaining suffering, that's the part that expiates sins. And I think a lot of Muslim patients will try to kind of put more on themselves to try to get that, that act of worship of being patient and feeling like, okay, this suffering is kind of like an extension to, and it's an extension of being connected to God, and you're getting it's kind of what life is about. Pain is really, for a Muslim person, is kind of it's the good and the bad, and so we take the good, but we cannot just say, oh, I don't want to deal with the bad. We have to also be patient through the bad, just like we were patient through the good. And so I think reminding your patients that, the other thing is also analgesia is often refused, especially for my own experience and my father's experience, because he wanted to pray. Prayer is the second pillar in Islam, and it's very important. And you can pray up to the point where you just are blinking your eye. And so you're not doing the full prayer where you're standing, bending down and putting your head on the floor. You can actually make changes to that. And so I think a lot of patients will say, I need to be spiritual present during my end of life. And so I don't want anything that will take that away from me. And I think we have to be sensitive to that and provide it in a way, and maybe approach it in a way that states, that you do value that as well for them, but you also don't want them to be suffering too much. Another, I think, thing to consider is the culture and beliefs around pain and cancer and things like that. And so there was a study that I read about Lebanese women in cancer, and a lot of women, a lot of cultures value themselves differently. And so in cultures where value is placed a lot on ability to reproduce, a woman's ability to not do that anymore is really going to cause her to have a lot of sadness, worry, anxiety, and those were not really treated in those settings. And so I think those learned behaviors are going to come over on the Western side, and when patients get here, those same things are still going to be present, because the environment might have changed, but the person didn't change, and their value system is not going to change that quickly. And so I think really approaching a patient and finding out, are you sad? Are you, what do you do? Who's your support system? Not every person that's come over from a different country has a huge support system. Some are by themselves alone in this country. And so I think addressing that is also important. The other thing is maintaining physical dignity and modesty. And when you're doing exams, putting on gloves, because that will create a barrier between you and the person of the opposite sex. If that's a woman you're caring for, she might have had just cleansed for prayer, and now you have to do an exam. Putting on gloves will put a barrier between you, and she can continue to do her prayer after you're done. And I think also providing spiritual dignity is important, like giving, when a person is praying, for example, having maybe the prayer times on the board, that might be important, and things like that. And so when a person is praying, and you know, for my father, one of the nurses came in and touched his hand to try to get his attention, and he had to get out of his prayer. And so when I came back into the room, he was very upset because, you know, he had broken his prayer. Now he had to make the wudu all over again and cleanse for prayer again and start all over. And so, and when I explained to the nurse, she said, "I'm so sorry." And I had to really educate and say, just put on gloves if you need to do anything. And that way you don't go ahead and break that prayer. And so I think those are things that are simple enough for us to understand and simple enough for us to change as providers, so that that dignity and that of that patient is really preserved as much as possible. Because when you come into the hospital, you lose a lot of control of your environment, of knowledge, I feel like, of what you know, what you can do for yourself, what you can do to help yourself. And so all of that is in the hands of a provider, of nurses, of CNAs. And so I think preserving that as much as possible is really important. I think another aspect to know as palliative care providers is that a lot of palliative care is not very well known in the Islamic world. And so again, when you bring that over to, and I found that out through my own research. I only found two, one was an interrogative review paper and one review paper. And both of those actually sourced a lot of research from Muslim majority countries. And so a lot of the palliative care that we talk about, and when you're approaching your families and your Muslim families, they will not know what palliative care is, because this is not something that is practiced where they come from. And if it is practiced, it's practiced only spiritually. Like in Iran, a lot of the nurses had no palliative care training, but spiritual palliative care was very well present and was being implemented by the nursing staff. And so I think knowing that you have to kind of explain to your patients and educate how the philosophy and palliative care intersect, and how Islam as well, and how you can facilitate, you know, a very human condition that's terminal illness, but also death, and not experiencing it alone in pain, and having dignity when you do this. And I think having that dignity preserved while you go through this experience is really important. And I think that this is further confused by when a patient is approached by a palliative care chaplain who is of another faith, like, for example, Christian or some other faith, and the patient, when they receive that, they're very confused about what exactly. They're not understanding that this is one person in a team, right? And so I think knowing that there's a bigger team, that's very important. For example, my father, when the palliative care chaplain came to him, he said, you know, you can really help me with something. And he was like, what? And he told him, well, if I, you know, convert you to Islam, I'm going straight to paradise. So do you want to do that? and so it's that kind of, you know, that kind of going back and forth. I think for us, my father was, you know, he said, yeah, let's talk about it. And they really had a good conversation about the two religions, and that helped him. I could tell that lifted his spirits. And so I think just explaining that palliative care is just not one person, but like a whole huge team. And that when you go home, you have that burden of, oh my God, who do I call? Because there's this something weird happening, that's healthcare related, and I don't understand it, and I don't know who to call. You have that nurse that you can call. And I think explaining those things is really important. One thing we did come up with from my DMP project was something called the prayer kit. And so the prayer kit was, like I said, the prayer is never it's never forgiven. You have to pray as long as you're sound of mind and you can blink your eye. And so I think one of the things that a lot of providers don't understand is if your patient is not safe to get up and do a wet wudu, meaning they have to wash their face, their hands, their feet, then you have to tell them, hey, it's not safe for you to do, and I don't want you to do a wet prayer. I don't want these things. I don't want you to get up and to try to attempt this. And so what happens is then that patient knows, okay, I can do a dry ablution. But the problem is a lot of hospital systems don't have the dry ablution kit, right? And so that's one of the things I provided to the Swedish hospital team. And so it was very well received, and was a lot of patients who, are at a loss for what to do next, were able to benefit from it. And I think as providers, as even chaplains, if we walk into the room and say, hey, I have this dry ablution kit. Do you think you might benefit from it? Are you allowed to be able to wash and do the full prayer readiness and things like that? And so I think, and then we also provided just a campus and a prayer mat is in there. They don't need to use the prayer mat. This is mostly for just the compass. Somebody else can use the prayer kit if they need to, but they can pray sitting. You as a provider can tell them you cannot stand up and pray because you might be lightheaded and fall. And so then they have to think, okay, I can sit. Can I sit? Yes. No, you cannot sit. Can I lay down and do this? Yes, you can lay down and do this. And so it can really be quite different. It can be changed all throughout. And then the last one I have is really this 5-part communication framework, which I love because it just goes through and has really it encompasses just anytime you're going to face a patient of different culture, regardless of religion, regardless of anything. I think it kind of puts it in a way that pulls out the spiritual needs, the cultural differences, negotiating any conflicts and things like that. And I think that's my time.
Oh my goodness, you are amazing. And I know you've given me some food for thought as well. I loved your practical suggestions about analgesia and kind of that redemptive suffering. Sorry, I'm hearing a little bit of echo of myself, but I want to open up the time to questions, but also just thank you so much for integrating your faith with your medical knowledge. So for both of you, you're both so knowledgeable.
Thank you.
And I see a request for Hoda to share the PowerPoint. I have Hoda's PowerPoint. It's been sent out to everyone. I'm happy to try to put it in the chat. It might be too big. If it doesn't work, then Janitra send it out as well. Do we have other questions in the chat? Just shout them out.
I'm going to just raise my voice. Hi, Hodo and Dr. Hodo and Rabbi Jason. Thank you so much for your time today. My name is Catherine. I'm the palliative care inpatient chaplain at Harborview. I heard just such a strong need in both the Jewish and Muslim faith to have community around the sick and around the dying. And I know that's one thing that we're really struggling with here in the hospital. As we all know, we're subject to new visitor restrictions, and trying to navigate how we can safely have visitors at the bedside, even at end of life, has been a challenge. And we've unfortunately been subject to quite strict restriction of how many people can come. We're trying to be as creative as possible about creating community for folks. And I wonder what ideas you have found successful, maybe when you haven't been able to visit someone that you would have in previous times, and how can we facilitate that better?
I think for speaking for myself, one of the things that as a nurse, I think that really works, and I think we're using quite a lot of, is just doing phone video visits. That's been very helpful. One thing I do will add to that is I had a patient that was end of life, and the family had not seen him for a month. He had COVID, they could not come into the hospital. And so I went to the nurses and I asked, do you guys have a DVD, like a tablet, and can you play the Quran in the background? And so she was like, well, where do I find that? And I said, you know, you can play it on YouTube, you can search it, and you can just play it on loop. That's really gonna help that patient kind of connect to something they know, something they used to hear, something that they're familiar with. And so when I said that to her and she did that, and the next day, one of the family members called on the patient's phone, and this patient was intubated for a month at that point. They were so happy to hear the Quran in the background. They were like, who told you guys to play that? You know, it was something that really set the family's mind at ease, because they were just so happy to hear that he was hearing that he was connecting to that. I think that's one of the things I can say. The other thing is, if a patient is awake and able to speak and interact, ask what they would like. There are a lot of Friday prayers that are now being streamed online, and so would they want to attend one online? And you know, their masjid might have it, their mosque might have it. For example, the one in the south end, Abu Bakr Masjid, they do stream their Friday prayer and the Friday, because before the prayer, there's a huge sermon that happens. And so they stream that. And so you can ask, hey, do you want to attend that? That might be something that, you know, helps them connect to their community.
Very little to add. Agree. Anything you can do, connect family, phone, or visually. Most services are being streamed as well because of the nature of the world we live in at the moment. So yes, connecting it that way. I would also say if there's a ritual element that can be brought in, for example, on Friday night, Jews will often light 2 candles to welcome in Shabbat. Often there will be some electric tea lights that various people can have or bring in. Or there's like a special bread called challah or grape juice. If there's a small, safe ritual element that can be brought into the room, that can be a nice touch or connection for people to still be able to feel part of their faith community, even if visitors are not allowed. But otherwise, everything was said. Same for my community as well.
I have a question. I'm a social worker with the palliative care team at Montlake, and I was wondering if you both can speak to in your faith communities how to best support families that might be facing a diagnosis around brain death or death by neurological criteria.
I think so in Islam, actually, this is one of the things I actually also found out through my research when I was going through my capstone project. And so one of the things I found out is in that 1988, there's a school of scholars that kind of anything that's not being talked about in the religion, it's talked about by these scholars, and they come to a conclusion and they pass that conclusion, whatever that is. So it's kind of like the Supreme Court, right? They say, this is the law, that's the law. And so this is kind of similar thing. And so it was actually passed that in 1988, that brain death was equal to cardiac death. And so, but does that mean that the Islamic, you know, the rest of the religious practitioners have caught on? No, that means that a lot of people will really just say life is life, and that's the end of it. And so I think having maybe talking around and maybe referencing that and having them go research it will help.
Again, agreed. It was around the 50 years, around the 60s, I believe, that brain deaths, when in rabbinic law, brain death started to become the primary accepted time of our neurological death, of when someone is seen as fully dead. So similar, speak to the family, help them research, help them understand, perhaps speaking with a rabbi or a chaplain who might be able to explain that that is when that is accepted as dead. That might be a way to help calm someone's concerns. I would also say in Judaism, I believe it's similar in Islam as well, but I obviously shouldn't speak to that, which is rabbis, scholars, Jewish teachers are not medical professionals. So when there's a medical question involved, Jewish law teaches us to refer to the medical professionals. So again, if a family's struggling, similarly help them do the research, help them understand. It's often probably more an emotional, is often an emotional denial or refusal to let go, which can be supported emotionally and spiritually. But if there's a medical question in the Jewish community, you're supposed to refer to medical professionals. And Judaism, throughout the spectrum, now accepts brain death. When someone is declared neurologically dead, death has occurred. Lauren, I'm happy to speak to you separately about that if there's any particular thing to discuss.
I think we have time for a couple of more questions if anybody's got something. I am curious about something myself. Dr. Mohammed, I run into that question of redemptive suffering, not with all Muslim patients, but with some Muslim patients. And I hadn't heard before this perspective that the suffering that's left after medical treatment is really that suffering that spiritually is something that's refining, that brings one closer to God. Is that a commonly held belief? Is that something that is commonly held within Islam, as much as something can be commonly held within a very diverse faith made up of many different people?
So this is something that I think a lot of it's very well known in terms of any person can go to any of their imams in the mosque and they'll be able to confirm that. And so I think a lot of people think that undue suffering is going to give them an extra sins being forgiven or something like that, right? And so it's the same idea. It's one of those things that, you know, a lot of people, when we fast, a lot of people try to fast an hour later. It's very, very, very well written that you cannot fast a minute after you're supposed to break your fast. And so you actually have to stop what you're doing to physically go find water and break your fast. And so it's the same thing with the suffering. It's very clear. There's not really any give, or there's not room for negotiations, so to say. And so I think that the negotiation is going to be, what is suffering, right? What is suffering for me? Like if I tell you my pain of 8 is normal, who are you to tell me that it's not, even if you can bring it down to a 5?
Okay. So there's that individual too.
Yeah.
And I see Deborah.
Yeah, thank you. Rabbi, if you would, and I know we have 1 minute, so I'm not quite sure how to cover this from the Jewish tradition, being within that tradition. Would you speak to organ donation, which I know is now accepted by all denominations, but particularly organ donation at the time of brainstem death? The reading that I'm doing has to do with that, if I understand it correctly, that once there is brainstem death, organ donation is acceptable.
Yes, that's my understanding as well, is that once brainstem death has occurred, that the person is considered dead, and anything that can be pikuach nefesh, anything that can save a life after death, save another life, such as organ donation, is permitted to begin. So yes, that once brainstem death or neurological death has occurred, the person is considered dead and organ donation is permitted.
And even if they're still breathing. Mechanical breed.
My understanding is yes.
Yes, thank you.
Oh my goodness, a huge thank you to Rabbi Jason and Dr. Hoda. I would sit here and chat with both of you forever if I could. So many thanks to you. I know we're at the top of the hour and I want to honor everyone's time.